Well, thank you very much, Dr. Delgado. I appreciate the gracious introduction. And because your survey indicated that a good number of our folks are over the age of 50, you'll understand why I feel a little bit like Artie Johnson here between the trees. But it's a pleasure to be here and really appreciate the invitation to be with you. What I thought I'd do over the next 40 minutes is talk a little bit about some of the factors that Dr. Delgado mentioned, build upon some of the concepts of aging, hopefully focusing on healthy aging, but opening up the discussion a little bit as to what it is that's facing all of us as far as risk factors and the specific pathophysiology of aging of the cardiovascular system and what we can do to help ourselves to improve our outcomes. Let me start with a little bit of general epidemiology, focus a little bit on some of the concepts that you've already heard about. It is absolutely clear that we are making an impact on cardiovascular disease mortality and morbidity. This is some of the data from the National Heart, Lung, and Blood Institute that shows over the past several decades we have indeed made, as I say, an impact in mortality. But it is just that. It is an impact in mortality. It is not an impact in preventing individuals from developing really the major aspect of cardiovascular disease that gives us our mortality and morbidity, and that is atherosclerotic disease of the coronary vessels. So in other words, this slide, I think, indicates that we're becoming very good at treating acute atherosclerotic plaque rupture, acute myocardial infarction, if you will. This argues for the wonderful systems we have in place for our emergency response systems. We're doing a great job at getting people into the cardiac catheterization laboratories and opening up blocked vessels, but we're not doing a fantastic job at preventing this disease to begin with. This is simply the prevalence of cardiovascular disease in adults, as you can see from the same data. And unfortunately, the majority of us in this room have already started on our atherosclerotic burden if you have not already had some anatomic manipulation of your atherosclerotic burden. So we're doing a good job at preventing mortality, but we're not doing a good job at preventing morbidity. And this is from the same data bank, the fact that, unfortunately, as we age, it is the cardiovascular disease that really outpaces all other causes of death in this country and, frankly, in other industrialized countries, even more so than cancer. This is an aging process, unfortunately, but it is not aging itself. And so I always like to use this quote about aging really being a disease itself. Absolutely not. We know that that's not the case. But unfortunately, the baggage that we bring along by living in the type of lifestyles that, unfortunately, the majority of us live in this country does bring along with it the morbidity and mortality associated with vascular disease. So how would we define successful aging? And I have my definition, and I know all of you have your own definition, but I would say that the goal is certainly longevity, but healthy longevity, and said another way, perhaps compression of morbidity, such that, you know, when we're reaching our 100th birthday, even if we're smoking, which hopefully we probably won't be doing, this is obviously a full life, one that is absent of morbidity. So let me go to the science a little bit. And in the cardiovascular world, we have a fantastic epidemiologic database called the Framingham Heart Study. And many of you, I'm sure, are familiar with this, have learned about it, and continue to read about it. This is a database started in the 1950s in the town of Framingham and in New England, and it really is a wonderful wealth of epidemiologic observations in cardiovascular disease. And now we have a significant number of individuals who have lived to age 85 and older in this Framingham Heart Study, FHS. And these individuals, by virtue of the fact that they're in this study, consent to one every year or so showing up, being examined, having data collected, and now we can go back and take a look at some very interesting relationships between what we would consider to be risk factors or risk determinants for cardiovascular disease and when they occur. So you can see that the original cohort of individuals were examined at least twice between the age of 40 and 50, and now we know that about a third of them have survived to age 85, and almost 20% of these individuals have survived to age 85 free of significant morbidities, living life like you and I hope to live life when we're 85. And what's very interesting is if we look at factors that are present in the 5th and 6th decade of life, we have excellent predictors as to what needs to be present, or perhaps what is absent, that leads to unhealthy aging. And I'll just, this is some of the baseline data, and you can see some of the numbers in relationship to the, I'm going to say, the garden variety risk factors that in cardiovascular disease we look at. But the point is that if we can accumulate data to allow us to not do just 10-year risk assessments on our patients, you know, in the traditional medical office visit in a cardiologist, I might go through and say, well, these are the factors that are present, and here's your 10-year risk for cardiovascular disease. But we all understand that we're not just looking for 10 years of morbidity-free life. We're looking for a complete lifetime that is healthy. So the rationale that in medical practice, traditional medical practice, you're going to see is getting away from short-term risk assessment and using data from studies such as the Framingham Heart Study to help us understand what is our lifetime risk and lifetime risk estimation for cardiovascular morbidity. So in other words, we want to estimate long-term risks that account for competing risks of death, cancers, other disease processes. The standard epidemiologic factors that we use right now in analyses really don't do that well. So this concept of lifetime risk is really defined as the absolute cumulative risk of an individual developing a given disease before death, and accounts for other potential causes of death. Admittedly, this is a population statistic that we try to apply to individuals in our practices. That doesn't work well all the time. Sometimes it's very difficult to translate epidemiologic data to clinical intervention. But let me just show you some interesting information. And this is the risk factor strata in these individuals that lived beyond the age of 85 when they were 50 years old. And it boils down, interestingly, to some of the very standard risk factors that Dr. Delgado already mentioned in his previous lecture, and that you and I and all of us have kind of been counseling our patients or maybe personally wrestling with over the course of our lives. So if we look at optimal risk factors at the age of 50, defined as you can see on this slide, total cholesterol is below 180 milligram per deciliter, absence of smoking, no diabetes. And you can see that if we just stratify this by optimal, that being optimal risk factor stratum, versus one or more than one major risk factors, defined as you can see on this slide, we can have a very good predictive model for problems at age 80 and beyond.